Hello, and welcome to another episode of the Melbourne Athletic Development Podcast. Today, I'm joined by Associate Professor Matt Bourne. Matt, thanks for being here today.
Hey, Jack. Thanks for having me.
So, just to give some context to the conversation, can you give a background to who you are, what you do, and your current position?
Yeah, sure. So I'm a sport and exercise scientist by trade. Did my PhD at the Queensland University of Technology under Associate Professor Tony Shield back in 2016. And since then, have been at a couple of different unis at Latrobe initially, and now at Griffith University on the Gold Coast.
Mhm.
So, as you said, Associate Professor in the sport and exercise science discipline, and really lucky to be part of a nice research group there, which is called the Griffith Centre for Biomedical and Rehabilitation Engineering. And it's quite a multidisciplinary research group focused on all things health and performance.
Okay.
Yeah, that's me.
So, I imagine has Tony Shields had a big influence on some of the research that you've done? Because obviously, a lot of the research that you're well known for is within the hamstring strain injury area.
Yeah, certainly has. Very fortunate to have Tony as an undergraduate lecturer back at QUT. And I remember as an undergraduate student thinking in my first research methods course, I'm never going to do research. I thought this is the most boring thing. But yeah, lucky to run into Tony and really developed a keen interest in this area, and I think that's
Mm.
true for a number of us that have sort of come through under Tony. So certainly
Mm.
had a big influence on our careers moving forward.
You're certainly a better person than I am for doing research. I know it's a big long term commitment for sure. So, look, you've done research in many different areas related to sports and exercise science. But again, as I mentioned before, you've done a lot of research in collaboration with other researchers around hamstring injuries. And obviously, if we think about hamstring injuries, they're the most common type of injury in a lot of team sports. And there's certainly been a proliferation of research done in the area over the last 10 to 20 years. But when we look at injury rates in a lot of common sports here in Australia, injury rates haven't necessarily gone down. So this is a question I wanted to start and pose to you and ask, why is this the case?
Yeah, really good question. A couple of things to consider, I think. Number one is that if we look at the demands of in terms of training and competition of most running based sports, there's a fairly significant trend up in the last 10 to 20 years. There was some work published looking at running demands in the English Premier League. It's a few years ago now, but if we looked at running demands now versus say 10 years ago, it's about 30% higher. And given that running is a common mechanism for hamstring injuries,
Mm,
um, you might argue that there's just increased exposure to that risky task. And so I think that given that we haven't seen this like analogous rise in injury rates, I would consider that a positive.
mm,
So I think we are making some progress. We're doing better in certain sports. I think if you look at the Australian Football League, there's been a bit of a downturn in rates of re-injury in particular, which is a positive. But you're spot on. Hamstring strains still represent the most common cause of time loss in
mm,
running based sports globally. So it's a big problem. I think maybe one other factor is that for whatever reason, um, uptake and compliance with evidence based injury prevention programs is generally poor.
mm,
So if we look across the hamstring injury literature, probably the most powerful tool that we've got is eccentric conditioning. Most of those large scale randomized controlled trials have used the Nordic hamstring exercise. I would consider that a mainstay of any prevention program. But
mm,
if you look across, particularly in Europe, parts of the US, the uptake and compliance with that exercise is generally poor. And so there might be barriers to implementation of evidence based practice, and there's certainly more to be understood there, I think.
Yeah, and that's actually a good lead into another question I had for you, and that is looking at some of the variations around common hamstring injury management across the globe. Because as you mentioned, actually, you do see variation. And certainly, and like I know you've obviously been a part of some of the research involved at looking at eccentric hamstring training to mitigate injury risk. And that may not necessarily be something that's implemented across the globe. And it actually interests me too, because when I think about variations that you see across the world, like I think you say in Europe, places like Germany or Sweden, they do lots of different types of injection therapy, as an example, or even use some more alternative therapies. And you might see some things like a lot more needling or acupuncture in, say, like China or Japan. And it's an interesting one because you mentioned evidence-based practice, but I also would think that there's a lot of really smart clinicians and researchers in different parts of the world who are trying to implement evidence-based practice as well. So why do you think you see such variations?
Yeah, it's a really good question, and I'm not sure. I mean, we mostly play in the exercise space, but even if we look at the variety of sort of exercise based interventions,
Mm,
they, as you say, they differ, depending on geographic region. So. In Australia, I would think in North America in particular, there's a fairly good culture around strength training,
mhm,
and most athletes see that as a core component of their athletic preparation. Um, if you go to parts of Europe, that seems to differ. So some people I've encountered are really resistant to even doing any strength training,
mm,
and it often comes down to an argument around specificity. I find so
mm,
people might argue that, well, hamstring strains typically occur during high speed running,
mm,
and so by following that logic, all of our sort of prevention efforts should try to mimic the loads, velocities, forces experienced during that type of a task.
mm,
I certainly think there's a role for specificity in training, um, but our view is more that structure also influences function, and uh, the stuff that we do in the gym can be quite powerful for altering structural characteristics that then translate to better function, better performance when you're doing your sport. So I think there's a role for both, but you're spot on. Depending on where you go in the world, there's very different, often strong-held views about what's appropriate. My view, I guess, as a scientist, is that to push the field forward, we really do need to be evidence-based, and I think unfortunately, with social media and the like, um, everyone's heard a good quote. Everyone's entitled to an opinion, but not every opinion's equal. And so there's with social media, anyone can have a platform to say whatever they like, and I guess it's challenging for students, for graduates, for clinicians. I think to really be able to synthesize and critically interpret a lot of uh, that literature and those viewpoints. So, my view is that we've always got to be as evidence based as possible. And I'll steal this from Tony Shield's functional anatomy class. But he always said you got to have your crap detector on. So um, we've got to look at the quality of the evidence. And we should prioritize that evidence, which sits at the top of the pyramid, like your randomized controlled trials and the like, and right down the very bottom is expert opinion.
mm.
So we've got to consider that, I think, when we're designing our injury prevention programs.
And I think also too, there's something very elusive to try and look for the newest gadget or the newest thing to do that's going to be the panacea. There's something quite sexy about that. I think a lot of people are looking for. And I think that's why certain people on social media are also very good at capturing someone's attention because they're providing something that's very different to the conventional message. I'm actually interested to hear though too, because the other thing I think about with the concept of evidence-based practice is we're obviously trying to look at the research and think about how we implement that clinically. But I'm interested, particularly in your position. I imagine you work a lot in talking to people who work in, say, high performance or in sports medicine. Do you see a lot of clinicians trying to push the boundaries on implementing new things to see whether, from a clinical perspective, there are actual other things that seem to be effective that we may not necessarily have studied or researched yet?
Yeah, I think you're completely right in saying that often what's being done at the pointy end of sport and clinical practice is far ahead of where the research is at.
Mhm.
So, and I appreciate that as a clinician, as a practitioner, you're treating the athlete or the patient. You're not treating a group necessarily, and that's usually what research is sort of focused on. So. Yeah, look, I do think, I've had the good fortune of meeting a lot of really good operators globally that are doing innovative things. But I think a common trend with a lot of them is that they've also got um, uh, quite an evidence based way of viewing things. So
Mm.
um, they're receptive to new information, new data as it comes in. I think this is a quote from Rod Whiteley, but he'd often say, "Data trumps theory." And the best guys and girls that I've seen around the world are open to changing their theories on things when new data comes in. So, but yeah, I completely agree that the evidence can only take us so far. It may not be applicable in every situation and every environment. We're often playing catch up with what some of these really innovative people are doing.
You mentioned before that something that there has been research to really support mitigating hamstring injuries is eccentric training. And I was wondering, can you actually elaborate a little bit more on that and on what eccentric training is and what is so unique about eccentric contractions that seems to be somewhat protective for hamstring injuries?
Yeah, sure. So, I guess if we look at the evidence and we look at the highest quality evidence, in particular the randomized control trials, um, they show that implementation of uh, eccentric or eccentrically biased hamstring exercises like the Nordic lead to roughly a 50% reduction in hamstring injury rates, so long as athletes are compliant. So, I mean, no brainer. You've got to do the program to get any benefit. Um, Eccentric training is quite unique. Uh, Probably the most important adaptation that we get from eccentric training is a degree of damage resistance. And we've understood that the repeated bout effects taught probably
Mm,
first year
mhm,
exercise science courses. We've understood that for a really long time. Um, so we get some unique adaptations within the nervous system, within the muscle, that probably confer that damage resistance.
mm,
A lot of the work that we've done has focused in and around muscle architecture. So what we see is that very rapidly, after introducing an eccentric stimulus to an individual, they get an increase in the fascicle length of biceps femoris longhead. That's the muscle that's injured sort of 80% of the time in running. And the mechanism underpinning increased fascicle length is still debated a little bit, but it likely reflects an increase in the number of sarcomeres in series.
mm,
So if you get more sarcomeres in series, it presumably leads to a bit of a rightward shift in the force length relationship of the muscle. And it also reduces the likelihood that each of those sarcomeres is going to be overextended during these active lengthening type contractions, as
mm.
you experience when you're in the terminal swing phase of running. So a bit of a mouthful, but I think the main benefit of eccentric training is the structural changes that you get within the muscle.
Mm.
So architecture is one. We've also done a lot of work recently around the muscle tendon interaction, changes in aponeurosis, geometry in particular. So I think that's a part of it as well, but there's likely many more factors. I think if you put all that aside, the thing to, that I guess it's an intellectual exercise to try to
Mhm.
understand how it works. But I suppose for clinicians, for practitioners, the main thing to be aware of is that, these eccentrically biased interventions lead to a really significant reduction in injury risk. So
Mm.
they're a good place to start.
And look, the reality is there's probably multiple mechanisms involved for its protective effect. Um, and I was actually just going to highlight there, just for listeners who aren't aware, you talked about it being able to shift the length tension relationship to the right so that you're actually able to produce your peak force at longer muscle lengths and reduce that strain. And it seems that an excess strain of the hamstrings, typically the long-headed biceps femoris, seems to be the key factor that actually causes a strain in the tissue to begin with. But one thing you mentioned there, and this is something that I've thought about before, is the benefit of doing something like a Nordic hamstring curl, because I know a lot of the work that you've done with eccentrics is looking at that. Is this the actual difficulty of the exercise? Because it's something that I think we often don't do enough of, is to give someone an exercise to say, all right, we're going to get you to do this motion where you're going to try and slowly eccentrically lower down and hold that for as long as you can. Where in the reality, most people fail to actually hold that position throughout the entire time. And you're obviously creating a lot of mechanical tension. And through that, there is this the benefit of increasing the tissue capacity by getting someone to do a task that initially they basically failed to do. Is that something that do you think is a really important thing to highlight and emphasize with doing something like a eccentric or a Nordic hamstring curl?
Yeah, I think probably the active ingredient in the exercise is the fact that it's supramaximal.
Mm,
And a lot of our work, particularly looking at the architectural adaptations to the exercise, has shown that that supramaximal intensity seems to be a really critical factor.
mm,
Um, and that's not to suggest that, if you have a hamstring strain, you need to be doing supramax Nordics day one. Um, some of our work led by Jack Hickey
mm,
actually does suggest that you can introduce them fairly early on in rehab. But that aside, I think the intensity is an important factor. So we've done training interventions where we've compared, say, bodyweight Nordics only versus Nordics with additional load as the athlete gets stronger. It's really only those athletes that have exposure to added load that continue to get these positive adaptations. So
mm,
yeah, it does seem to be an important factor. I think it's likely why the Nordic is so useful in these randomized control trials as well. A lot of people, come to us and say, well, what about other exercises like, an eccentric sort of hip extension task? And by the way, I think that's a great option as well, and potentially a great alternative. But it's often difficult to match the intensity of a even a bodyweight Nordic
mm.
with quite a heavy, RDL or stiff leg deadlift or something, right? Often other things like lower backs are the limiting factor. So yeah, by chance, I think it's ticking, the Nordics ticking a lot of these boxes that make it really useful for getting these adaptations.
And for people who are unsure about, comparing, say, doing a hip extension type bias movement versus a Nordic, my recommendation is have a go at doing each because the difficulty of doing a Nordic hamstring curl and some of the DOMs that you get from it is much more significant for if you have never actually done that stimulus before.
Yeah.
One of the other things that you mentioned about its potential mechanisms associated with mitigating hamstring injuries for something like a Nordic hamstring curl is muscle architecture. Now, this seems to be somewhat of a controversial topic depending on who you ask in terms of whether that is a key mechanism. And I know I've interviewed someone else before, Tony Blazovic, who you may have heard talk saying that he's not necessarily convinced that increases in fascicle length we can be always a recurrence of eccentric hamstring training. And I know he's mentioned some of the research done in, say, rat models or even some human models where a novel stimulus, whether it's a concentric, eccentric, or isometric contraction, can increase uh, fascicle length regardless of the contraction type. So I was actually interested to hear your thoughts on this to see, is there more do you have more confidence to think that eccentric training can really elicit much more of an increase in fascicle length compared to other types of contractions?
Yeah, I do. And I preface this by saying that, really big supporter of Tony Blazevich's work,
Oh
and
yeah,
he's
he's
done,
great. Yeah, yeah.
done a lot of great stuff in this space. Um, all of the work that we've done, and others, particularly in recent years, has shown I guess an overwhelming body of evidence to suggest that contraction mode does seem to be an important driver of these adaptations, at least in biceps fem long head. I think probably the first study that our group did in this space was led by Ryan Timmons
Mhm.
as part of his PhD. And so in that study, he had two groups. They both trained on an isokinetic dynamometer. So I don't know if the listeners are familiar with that, but sort of like a seated leg curl, leg extension type device. Now, one group trained concentrically only, and the other group trained eccentrically only. And you can do that with the isokinetic dyno setup. And I guess the important thing to highlight here is that both groups trained at quite long muscle lengths, which is
Mm.
likely also a factor in stimulating these changes.
Yes.
So the eccentric group, as we'd expect, got a very significant increase in fascicle length
Mm.
within about 2 weeks of training. Those adaptations kind of plateaued a bit after that. And then as soon as training was stopped, they basically went straight back to baseline within a few weeks.
Mm.
The concentric group, and again, even though they trained at quite long muscle lengths, they went in the complete opposite direction. So they actually started to get a decrease in fascicle length, which continued throughout the intervention. And then we also had this detraining window at the end. Even after they stopped training, they stayed shorter. They didn't go back to baseline.
Mm.
Um, and so we've done a number of studies since, looking at the role of different exercises. So, one study that I did in my PhD compared 10 weeks of training with the Nordic versus 10 weeks of training with a 45-degree hip extension task. Now, the hip extension task exposes the hamstrings to much greater changes in length, right? It's you're going through sort of full range of hip flexion there,
Yes.
with an extended knee. And in contrast to Nordic, you're basically stopping in a neutral position. But what we saw was, technically there was no significant difference between the fascicle length increases. Both groups got much longer within 5 weeks, and that continued out to 10 weeks. But if you looked at the effect size, there was actually a large effect size favoring the Nordic. So it was something like 2.2 centimeter increase in average following Nordics, and 1.5 thereabouts following hip extension. So my hypothesis going into that was, hip extension is definitely going to be
Mm.
the winner here. The only difference between those exercises is Nordic was eccentric only, and the hip extension, they went down and they came back up.
Mm.
And so, yeah, we've done a number of studies since, as I said, looking at different exercises. We've looked at concentric only training, isometric training, eccentric training. Eccentric quite consistently gives us this fascicle lengthening response, so long as the intensity is sufficient enough.
Yes. Okay.
There's been a little bit of work out of University of Queensland recently as well. Some of it's published. I think some of it is still in preparation. But they used a really sophisticated technique to actually look at the level of the sarcomere and what's happening there. And so
Mm.
they found, I think, don't quote me, but after 3 weeks, they saw an increase in sarcomere length.
Mm.
Um, no addition of sarcomeres in series. But their more recent work, which, as I said, is published in a conference abstract, but I don't think the full paper's out yet, showed that beyond that, there was a radical increase in the number of sarcomeres in series. So I
Okay.
think, that gives us some idea of, what's driving the fascicle
Mm.
length increase.
Well, that was actually the next question I was going to ask, because when we think about increasing fascicle length, it's suggested that we get more sarcomeres in series, like you mentioned before. But the other thing that you discussed too, that you've done some research in recently, which I'll be interested to hear, is about changes in the aponeurosis of the surrounding muscle. Because the way I think about it is, when you've got a pinnated muscle, and you've got a particular pennation and the fascicle crossing between the two aponeuroses. If the aponeurosis changes in, say, like this way, you could technically make it look like the fascicle gets longer because it gets stretched. And so I was interested to hear, do we have an understanding about whether the increase in fascicle length is because of changes in the characteristics or the geometry of the aponeurosis, or because of an increase in sarcomeres or in series, or potentially both?
Yeah, yeah, really good question. The changes in the stiffness of the aponeurosis or the
Mm,
tendon is very much a possibility here that could be contributing to some of these changes. So if you've got a stiffer tendinous structure, that might just mean that the fascicles are sort of pulled or elongated more. So that would give the illusion that they're increasing. It probably, to my mind, it's not something which has been explored well, but it probably doesn't explain why we get these sort of differing responses to say concentric and eccentric contractions. So we've done some work led by one of my PhD students, Steph Lazarchuk, looking at the effect of different types of interventions, mechanical loading on tendon, aponeurosis, geometry, material properties. There's no clear effective contraction mode on that. So
okay.
so long as intensity is sufficient and strain on the tendon or aponeurosis is sufficient, you'll likely get an increase in stiffness. So it's a possibility, but for me, it probably doesn't explain why we get this differing response between contraction mode. I think that the work led out of University of Queensland, that's Glenn Litchwark's group, and he's now at Queensland University of Technology. Apologies, I can't recall the first author's surname, but I think that's probably the strongest evidence to date, which tells us about the mechanism underpinning these vascular length increases.
In terms of
There's
being
also
sarcomeres in series.
yes,
Yes, yeah,
yeah.
okay.
I mean, there's also the early sort of the rat studies and the like that you alluded to earlier. So
Yes.
those those studies allow the researchers to be a little bit more.
So these are the ones you're talking about where they break the leg and lengthen the leg, the Gold Sphinx research I'm thinking of?
Well, there are those. There's
Yeah.
also studies where they've taken rats and they've had them run uphill
Mm,
or
mm.
downhill, and so
Yes,
uphill,
yes.
predominantly concentric, downhill, predominantly eccentric contractions, and then they've excised I think it's vastus intermedius of the poor rats, and they're actually able to count up the number of sarcomeres. And so what some of that work showed many years ago now is that you got an increase in serial sarcomeres. Well,
Mm,
uh, following downhill running or eccentric training, those rats had far more sarcomeres in series than the group that ran downhill, and then the group that didn't train as well. So we've got different lines of evidence. I'm sure Tony Blazevich would have spoken to you about some of that as well. But
mm, mm.
I think probably the strongest, for me anyway, the strongest evidence to date comes from those studies that have used those techniques to estimate sarcomere number
Mm.
in vivo in humans. So
One thing I think about with soft tissue injuries is we talk about the muscle tendon unit, but as we've both mentioned a little bit about, is the aponeurosis or the fascia. And that seems to me to be a very important element to consider, because it does have um, quite stiff properties, and we do see force transfer from the muscle to the aponeurosis. And as I was mentioning before, if we get changes in the position of aponeurosis, that influences the dynamic architecture of the muscle, which you would you would think that influences the behavior of the muscle tendon unit. Is there more interest in research being done in looking at the aponeurosis and thinking about how we need to implement the fascial system into muscle tendon models?
Yeah, there definitely is. So that's really been the focus of Steph Lazarchuk's PhD. She's just coming to the end now, and so she'll have a few papers that are they're under review, but should be out in the near future. So I guess to provide some context, a lot of this work around the importance of the aponeurosis and aponeurosis to muscle geometry was done probably 10 years or so ago. Trying to recall the Sylvia Blemke's group out of the US
Okay.
led a lot of this. Again, sorry, the first name, the first author name's just escaping me at the moment. But basically, what this showed was that individuals that had, and this was a computational modeling type study, individuals that had disproportionately small aponeuroses, proximal aponeuroses, relative to the size of the muscle, and sorry, this is in biceps fem long head, experience greater localized tissue strains around that muscle tendon junction, that proximal muscle tendon junction. So, we look at all the epidemiology data. We know most injuries are happening in biceps fem long head. Most of them are proximally, and the muscle tendon junction is kind of that weak point of the MTU. So that work was really nice. Again, it was sort of computational modeling. They also did some dense imaging type work, which supported that. They basically found consistently that that there was a high degree of variability between people in this aponeurosis size, but the size of that structure relative to the muscle, if you had a small aponeurosis, you think of that a bit like a force transmitter and a big muscle as the force generator, that increased strains. And the reason for that, I suspect, is because you've got more force from a bigger muscle going through a smaller area, so that increases the stress and therefore the strain. So problem is it's never been examined prospectively, so it's not been established as a risk factor. And when Steph did this systematic review, basically synthesizing all the literature on lower limb tendon adaptations to training, not only had no study looked at hamstring aponeurosis geometry, there wasn't a single study that had looked at geometric change of the hamstrings or really anything else after training. So that was a big gap. So she's done some work. She looked at aponeurosis geometry initially in people with a history of hamstring injury, and her work actually suggested that previously injured limbs had a larger aponeurosis, which potentially a response to either injury or rehabilitation. And then she's got some work on the way, which has looked at the effect of different exercises on targeting those structures. And not to give a lot away, but it seems that the muscle, as you'd expect, is much more responsive to some of our common short-term interventions anyway than is the tendon and aponeurosis. So we've certainly got a lot more work to do there to understand if this is a risk factor, then what's the optimal way to change it. I would say actually, and just to a little bit left of field, but we often talk about, well, how can the Nordic be so effective? Because it's not functional, right? It doesn't replicate high speed running, and that's totally fine. One of the things that we do know about the Nordic, though, is that it increases biceps femoris fascicle length very, very rapidly, but it actually doesn't stimulate much biceps fem long head hypertrophy. Even 10 weeks of training, I think we saw something like a 4 or 5% increase in muscle volume, which wasn't significant. And so it's conceivably another mechanism by which this exercise might be so effective. It's not changing that force generator component, but it is positively influencing architecture.
Well, and I think what that highlights too, and this is something that John and I have discussed many times before is that relationship between tissue capacity and biomechanics. And when I say biomechanics, we could think about it from a macro level in terms of actually how you move, but then also at a micro level in terms of the behavior of the muscle tendon unit. And I've asked this question many people. In fact, it's probably a good one to ask you is, do we think about changing someone's tissue capacity and then you get a reorganization of the system that influences the mechanical output? Or do we think about changing the biomechanics and then consequently we change the forces through the body and we see changes in tissue capacity? Do you have any thoughts on this in particular?
Yeah, really good question. And you're right. All failures, all tissue failures, have a common mechanism. It's when the force or the loads applied to the tissue exceed the current strength of the tissue.
Mm,
And so you can theoretically manipulate either side of that. And I guess a lot of our work has been focused on manipulating the strength of the tissue side of things. I view a lot of what we do in the gym as structural,
mm,
right or wrong. I think sort of 90% of the benefits there are structural. It's a good place to alter architecture or alter size of muscles and things like that. But then the other piece of it is also potentially changing the way in which athletes move
mm,
to safeguard against injury. So I think so on the structure side of things, the evidence is there's a fair bit of work. The evidence is pretty clear as to what's effective and what isn't. I think we've got much less of an understanding around um, the optimal. Number one, whether biomechanics is uh, really a risk factor for hamstring injury in particular.
mm,
And then if it is, then the optimal way to change it, or even if we can change it, particularly in sort of team-based sports and
mm,
field-based sports. So there's the modeling studies which were done years ago, showing that like when you have excessive anterior tilt of the pelvis, that's likely to increase strain on the contralateral hamstrings during that late swing, and so that makes total sense. And I think you speak to good uh, track coaches in particular, and there's usually that's usually something that they try to address in their training.
mm,
Um, I think there's just not been a lot of good prospective studies with sufficient numbers of participants and injuries to give us a clear idea of whether it's a meaningful risk factor. So it's quite possible, right, that that athletes just adapt. That the sort of structural characteristics adapt to the way in which they move,
mm.
um, and so that's one possibility. But I think there's certainly more to be done there. If it is established as a risk factor, which it may well be, then I think we also need to understand, can we change it, and what's the best way to change it.
Yeah, and I think of actually, I can't think of his first name, but Mendegucha's work, where, I mean, some may criticize it because of the fact that I think of some of the research he's done where they do a combination of um, gym type work and running type work to change biomechanics, and you actually see changes over time. And I think that's actually probably much more reflective of what we do in the real world, where if you want to change someone's movement patterns, you're going to do a combination of work in the gym, doing more controlled, isolated stuff, and then also work out on the field. And it's the reality is obviously all of is going to have an influence on it, but there seems to be certainly that as you essentially build up certain tools within the musculoskeletal system, it does give you more capacity to then change some of the movement patterns that you have as you implement those tools into your neuromuscular patterns.
Yeah.
Mm,
Yeah, I completely agree, and Jordan's done great work in this space, and
mm,
he's published get the name of the paper. It's a multifactorial rehabilitation algorithm paper. I think it's a great example of an approach to rehab.
mm,
Very comprehensive, includes a lot of things, and as you said, I think in the real world, people are doing a combination of stuff in the gym and stuff
mm,
on the track or the pitch or the field. I guess the the challenge from a purely from a research perspective is it's difficult to isolate what the active ingredient is
Mm,
in multimodal programs like that. And so if you've got not to suggest that it doesn't work, but if you don't have time or resources to throw the kitchen sink at someone, and you've only got a finite period of time with the athlete, then what do you prioritize?
mm.
And that's where I think having an evidence based hat on is useful. The evidence would suggest that eccentric training is probably the most useful thing that we've got. So I would have that as front and center. I tend to we would, not that I rehab a lot of athletes personally, but I think there's scope for having or it's sensible to introduce eccentric loading before the athlete is doing a lot of high speed running, because you're not going to tear your hamstring doing a Nordic. You
Yes.
possibly will tear it running, and
Mm,
so as you said, when you're unaccustomed to Nordics or other eccentrics, you get a little bit of micro trauma, a bit of damage, soreness. That's why most athletes hate it.
mm,
But as you know, you very quickly adapt to that stimulus, and within a couple of weeks, you won't have any soreness. So
mm.
I think there's a place for introducing eccentrics, sensibly, um, early on, perhaps in a program, and that gives you these favorable adaptations that then protect you when you start introducing high speed running. But yeah, totally agree. It's complex, and it's never there's never one single exercise or intervention that's going to work.
No, and look, that's always something I think about in terms of the differences between a clinician or a coach and a researcher. Because I think as a clinician or a coach, you're thinking, I just need to get the best outcome of this person. I'm going to do A, B, C, D. That obviously can muddy the water of going, well, what is actually having the biggest influence, as opposed to from the research perspective, where it's like, no, no, let's control this so we can see what the relationship is between the intervention we apply and the outcome. But I also sometimes think, though, too, about when you're applying multiple interventions, is there a synergistic effect between those different interventions that leads to an outcome that's not necessarily just the sum of those different parts, but actually an exponential effect because of how the human body works in response to applying multiple stresses at once? And that's probably more of a philosophical discussion too, but I often think about that from a research perspective of how does that influence maybe how research is done? Because do we see different effects that are more exponential in nature if you apply multiple things at once?
Yeah, really good question. I think, from my view anyway, we in sports medicine, S&C circles, we often get caught up on, the exercise,
Mm.
and the Nordics a good example, because half the world hate it, half the world love it. You see the most fierce debates on social media about whether you should or shouldn't do the exercise. I think that's the wrong way to look at it. I think the best way to approach this is, what are the adaptations that you're trying to elicit
Mm.
to reduce your risk of injury. For hamstring strains, we've got a reasonably good understanding of what those things are, but it's the same for many other types of injuries as well, right? What are the things that we can change, and what should we prioritize to reduce risk? And there's many ways to skin a cat, right? There
Mm.
might be, we've got good evidence that Nordics are really effective, for example, at increasing fascicle length.
Mm.
Um, there's probably lots of other good alternatives. So, long length exercises like hip extension, they're also pretty good.
Mm.
I think if you had an eccentrically biased hip extension, that might be, even better. Um, and so I think we need to get away from looking at an exercise as good or bad, and more, as you said, it's a tool in your toolkit to get the response that you want. And if you can't implement a given exercise because you don't have the equipment or the resources, or your athlete hates it, well, maybe you can look at something else, and hopefully you achieve the same response.
And I often think too of this very simple thing of when you do your assessment, where do you identify to be the biggest deficits? Because an example, like I've had an athlete before who um, has been doing eccentric Nordics for a long time, has amazing capacity, can do single leg eccentric, Nordic hamstring curl with weight. and he still gets hamstring strains. And that's not to suggest that that hasn't helped him, not at all, but that his deficits laid elsewhere that he actually needed to address. And I think again, that part of that is probably also the human psychology, where we like to follow kind of simple protocols, but sometimes that can also lead to problems because you may miss something that's also needs to be addressed.
Yeah,
Mm.
yeah, yeah, spot on. And I think for a long time, sports medicine got caught up on predicting injury, and
Mm, mm,
I think it's pretty clear that we're not very good at that.
no.
And there's a number of reasons for that, but I think it's probably worth educating practitioners, educating the athletes and clients as well around even just simple things like the difference between absolute and relative
Mm,
risk. Right? It's easy to you know see a headline that says, "Oh, well, do this exercise and you have 5 times reduced risk of X happening,"
mm.
and it's easy to grab onto that and say, "Oh, well, good. If I hit this, then I'm safe." But it's the absolute risk might be quite different. So, yeah, just a bit of nuance there.
And also, I think just to add to that, I think people need to remember that when we look at risk factors, it's at a population level. So, if you have a group of people, you know that certain risks, certain things will be increase or decrease their risk. And so, but at an individual level, you may not get that nuance because you don't know where that person is in the overall average group of people if you assess a larger group. You mentioned some of Jack Hickey's work, and so he's done some interesting stuff looking at the implementation of doing some heavier type of hamstring loading early on following a hamstring injury. And if nothing else, some of his research highlights that actually implementing it early on certainly doesn't have a negative effect in terms of outcomes for recovery and rehabilitation. And when I think about that, it seems to be very contradictory to the simple idea of if you have a strain, do we not want to be protective to the amount of mechanical tension that goes through that injured area? So I was interested to hear your thoughts on that research and what does that highlight to you and what do we need to think about as coaches and clinicians in applying potentially higher mechanical loads early on following an injury than we would consider to be safe?
Yeah, I think Jack's work is really innovative, and some of the nicer stuff to come out of our group in recent years. Um, I think Jack's approach is moving away from traditional models of sort of progressing rehabilitation, based on time and the like, to being very much criteria based,
Mm,
and objective in assessment and prescription. So Jack, I guess if we, if we took a step back and we looked at conventional approaches to rehabilitation, I do think that quite often we're too cautious, especially early on. Now, this is a very broad generalization, but often what we see is complete avoidance of
mm,
eccentric or active lengthening type contractions, depending on the severity, of the injury. But usually in the first kind of couple of weeks, few weeks, there's very limited exposure to that. Often, we see clinicians starting with either no load or sort of low level isometric stuff that progresses to concentric, and then maybe at the very end of rehab that they're introducing some eccentrics. I think one important thing to highlight is that an eccentric doesn't have to be a supramaximal eccentric, so you can start with some lower level stuff. And Carl Askling has done some great work in sprinters, jumpers over in Europe, as well as I think it's sub elite footballers. Looking at, he had these two different interventions. One was called the L protocol, kind of like lengthening type exercises, mostly eccentric biased, versus a conventional protocol, which was sort of shorter length, more traditional stuff. And he saw really positive effects in terms of return to sport rates and re-injury rates in response to that lengthening stuff. And there's lots of other evidence that supports that now. So I think there's my recommendation would be to be sensible, but to introduce eccentric
mm,
loading earlier on than is typically done. and be objective in terms of when you apply that. So Jack's, if you read through Jack's paper, he kind of outlines that quite nicely. When the athlete could hit X criteria, they progress to the next step. And
Yes.
from memory, what he saw was most athletes, acutely after a hammy strain, were able to start introducing eccentrics, quite early. And don't quote me, but I think most were doing Nordics, within the first sort of week or so.
Mm.
And of course, a lot of people are like, that's terrible. But those athletes progressed very well. He also looked at the effect of pain, and so when they had a pain threshold that they trained to, so I think it was a 4 out of 10. Those athletes actually experienced slightly greater improvements in strength and fascicle length at the sort of cessation of rehab. I guess I'm not sure if that answers your question, but I do think that we don't want to be too cautious in
No.
rehab, and I think the biggest risk, right, is that if you're the highest risk is when the athlete returns to sport, and probably that first month or so after returning to sport is where a lot of the re-injuries are happening.
Mm.
And I don't have good evidence to support this, but I suspect that often what we're doing is there's a gap in terms of what we're preparing the athlete for at end of rehab and what they're exposed to when they go back to sport. So they've got to sprint, they've got to have exposure to these really forceful long length eccentric contractions, and so if they haven't got those adaptations through rehab, then they're not in the best position going back.
No, and look, I was just going to say that exact thing too. Of when you have a hamstring strain or any injury, if your load goes from here to here, you're going to have a large detraining effect. So the way I look at it is, how do you mitigate the detraining effect by maintaining some type of mechanical load? And obviously, the higher the load, the better. And I think for me too, that really highlights that. I think sometimes we underestimate how adaptive the neuromuscular system is, because it makes me think, is part of the protection related to a hamstring injury, as an example, where you do a Nordic hamstring curl early on, is that you get a change in the neuromuscular patterns that influence what part of the hamstrings are working. So it actually can even almost isolate, reducing the amount of force within the area of strain and increasing the force in the surrounding musculature, so that you can still continue the task. You still maintain a high mechanical load to mitigate detraining of other tissue, and then you still get potentially the benefits of the secretion of certain, autocrine, paracrine factors that maintain or influence things like hypertrophy or activation of satellite cells that help to with the remodeling process. And I think that's something that we need to perhaps appreciate, of how responsive and adaptive the human system is even under injury. Mm.
Yeah, absolutely. I think there's some nice work which has come out of Europe. Jörg Schuurman's led some of this in her PhD from Ghent University, and she sort of looked at this concept of load sharing. They did some
Yes.
stuff with functional MRI, and sort of showed that within a given task, it was a fatiguing sort of leg curl task to exhaustion. Um, Previously injured limbs had different patterns of coordination to
Mm.
uninjured limbs, and
Mm.
actually those sort of those patterns, which is basically reflected I think in the leg curl, they basically had reduced semi tendinosis recruitment, and they had a greater reliance on biceps femoris. Those guys, and this was a amateur soccer cohort, had a greater risk of injury going
Mm.
forward. And so I think, there's certainly a lot more to be learnt around these patterns of intramuscular coordination, how they change after injury, potentially how they, alter load sharing and, by extension, fatigability, I suppose,
Mm.
and influence injury risk down the track.
Now, I'm in cognizant of time, Max. I know you've got other things to get on with your day. How much more time have you got before you need to head off?
For another 10 minutes or so.
Okay, because one other question I wanted to ask was about the assessment of muscle architecture static versus dynamic, because a lot of what we do when we look at muscle architecture at the moment is ultrasound with the muscle at rest to look at the fascicle length and pronation angle. But and I know there's been some research looking at this, probably more so in animal models of dynamic muscle architecture. And I know you're probably familiar with some of Thomas Roberts or Emmanuel Aziz's work, where they've looked at the behavior of the muscle tendon unit is also influenced by the velocity and force characteristics of the task. And that you actually see changes in the position of the aponeurosis and therefore the position of the muscle fascicles to influence whether the muscle can have a higher force or a higher velocity type of contraction. And so I'm interested, is there any developments of looking at the dynamic behavior of muscle architecture of, say, the hamstrings with certain tasks? And are we getting any indications about how that can change and adapt in response to different types of training stimulus?
Yeah, good question. It's not something that we've looked at. I'm not across most of that recent literature, but I think what you're getting at there is this concept of muscle gearing, which is
Yes.
sort of how the muscle tendon unit shortens relative to the fibers, and
Mm,
in pennate muscles, what you see is you see fascicle shortening, but you also see fiber rotation, and that has a number of benefits. So it can basically amplify force in high force, sort of low velocity contractions, and it can amplify sort of velocity in low force contractions. And
mhm,
so there's a number of sort of reasons for that behavior. We haven't looked at that from the perspective of injury risk. I think it is of interest, particularly given our focus on tendons lately. So, as tendon stiffness in particular changes, that might change that dynamic behavior of the muscle tendon unit. But look, most of our work involves these static measures of architecture, and I mean architecture. If we just isolate that by itself, that does have a direct flow-on effect to function
mm,
during
mm,
those dynamic contractions. So when you have a fiber, when you have muscle with greater pronation angles, it's basically, as you know, it's sort of a space-saving mechanism to allow us to stuff more sarcomeres in parallel. So that's going to influence the physiological cross-sectional area of the muscle. Higher the PCSA, the higher the force generating capacity. They're basically proportional.
mm,
Um, but we also have the fascicle length. And so from a functional perspective, if you've got longer fascicles, presumably you've got more sarcomeres in series. That has implications for force length characteristics and damage susceptibility. But it also influences the contraction or the shortening velocity of the muscle. So longer fibers, they can contract more quickly. And there's some nice work done years ago now looking at sort of sprinters versus non-sprinters versus distance runners, and basically you see longer fascicles in the quads and the calves of sprinters versus these other athletes. And
mm.
so yeah, there's certainly functional implications from those static measures. But in terms of the dynamic behavior, yeah, probably not something that's been looked at, but certainly something to earmark moving forward.
Well, and with that in mind, actually, I was going to ask, what's on the horizon for you? What are you interested to continue to look at and explore? And are there any particular things that you're interested in looking at that haven't necessarily been well studied yet?
Yeah, good question. I mean, I think we've got in the hamstring space, we've got a couple of different lines of research at the moment at Griffith, at least. One is around sort of exercise selection, and what we're hoping to do there. We've done and continuing to do work in sort of understanding injury risk, but the next piece to that is how can we provide practitioners with a sort of an evidence base from which to prescribe exercises to target different things, whatever that might be. So we're doing a fair bit of stuff. Dr. Tyler Collins is a former PhD student of ours and on staff at Griffith now. He's doing a lot of work in the musculoskeletal modelling space. So actually going from these sort of rude and crude measures of EMG, like
Hmm.
sort of activation of muscles, to actually use EMG to inform MSK models to estimate muscle forces. So there's some really interesting stuff that'll be coming out from him in the near future. He's done some work looking at gluteal muscles, but we'll be looking at a lot of other lower limb muscles there. So there's that stuff. I think that stuff is going to be really critical to inform future randomized control trials, which we'd like to run eventually. But we're also continuing this work into understanding injury risk, and it's been it's sort of the holy grail of sports med to predict injury, and I think we need to move away from that.
Mm.
It's more about understanding what factors are influencing risk in the individual athlete, and then rather than a sort of a shotgun approach where everyone gets the same thing, hopefully we can tailor and target interventions towards different factors. Um, Dave Opar, Professor David Opar now actually led a really nice paper in the AFL. I think it's published 2023 or 2022, looking at screening risk factors in Aussie rules footballers. He looked at assessing at single time point versus multiple time point, and that's something we're interested in as well. So introducing more regular measures.
Mm.
That study suggested that a number of these factors like strength imbalances and architecture were significantly associated with injury risk.
But do you see
But
fluctuation though with a fair bit as you measure more?
they did fluctuate. Don't quote me on the numbers, but there
Mm.
was some change. So he looked at once in preseason versus three times across the season, and so there was some fluctuation in some factors. So for example, I think it was eccentric knee flexor strength had no relationship with injury based off preseason measures, but if you looked at multi-time points, in the between limb imbalance came out as a
Mm.
significant factor. Measures of architecture were related to injury at both time points as well. But I think the really interesting thing is in using that to I guess predict injury. So one of the things that we look at from a statistical perspective is something called the area under the curve, and the AUC, you'd see it written in papers, and you can kind of think of that as a percentage of athletes that we correctly classify as getting a subsequent injury or not. So, an AUC of 0.5 or 50% would be like flipping a coin, and an AUC of 1 is perfect prediction. So, you'd always like to be closer to 1. If you look at, that work, I think it was, so the area under the curve range from kind of zero point 0.6 something, 6.5-ish to around 0.7. And so you might say, well, great, it's away from 0.5, and so we're correctly classifying, say, 70%. But to play devil's advocate, 70% is still technically closer to random chance than perfect
Mm.
prediction, and that's
Mm.
that's probably something important to keep in mind with when interpreting a lot of this risk factor data,
Yes.
is that if you're using this to predict injury, you're going to be wrong a lot of the time. Um, and so, but that's probably not the point of it. It's more to, I guess, understand your athlete, understand what's influencing risk in that individual athlete,
Mm.
and then to guide the delivery of interventions to reduce that risk. And so that's probably the other area of research that I'm really interested in at the moment. And we're starting to look at some different things. Tendon aponeurosis geometry being one
Mm.
of them. But yeah.
Where can people follow your work, Matt?
Uh, yeah, good question. I'm on it's called now X.
Oh, yes, of course,
It's
formerly known as Twitter.
Mborn5, although probably not as active as I once was. Otherwise, if anyone does have questions, I'm very happy for you to reach out on email. You can
Mm.
type my name into Google, and that'll pop up on the Griffith website, or happy to give you a link to chuck
Yeah.
up if that's helpful.
Yeah, Matt, thank you very much for coming on and giving up some of your time. I think it'd be great to get you on again at some point in the future to get more updates on what you're doing and I know there's actually a few questions I had we didn't get to today, but that's all right. So thank you again. And again, just for listeners who are following the podcast, again, please like, subscribe, leave a comment on YouTube or whatever podcast platform you listen to us. It's really useful for us to help spread the word. So thank you very much, Matt.
No worries. Thanks for having me.